Structure with schizophrenia and bipolar. So the concept definition. So mood and affect refer to emotional states observed in clients, whereas mood is the client's emotional state, affect is the outward expression of that emotional state. So someone's mood is subjective. It's not something that we can assume. Someone has, a certain feeling, they're in a certain mood. But what we can assess objectively is their affect. And we'll talk a little bit more about the variations in affect in the upcoming slides. So these are important definitions to know, all right? You need to be familiar with them because they are oftentimes, clinical manifestations, side effects of medications that you see with patients who are schizophrenic or, possibly even bipolar as well. So to go through them real quick, akathisia is purposeless movements. It's repetitive, and it is oftentimes a side effect of antipsychotics. Catatonia, so these are sort of like bizarre motor movements or positions, sort of posturing that patients can do. They may hold themselves in bizarre postures or bizarre like positions. So it's, related to their motor movement. Delusions. So these are false, fixed beliefs in reality. So delusions would be, that the patient truly believes that something is true that is absolutely not true. Like an example of that would be that a patient might believe that they no longer have a stomach anymore or something like that, or they have green worms that live inside them, and they truly believe that. So those are false, fixed beliefs. Okay, with those, we want to focus on their feelings. If they are experiencing them, if they say that they have no stomach or they have no heart, that could be interpreted as, you must be feeling empty or you must be feeling lonely, that sort of thing. So you focus on their feelings, what's kind of behind the delusion. Echolalia, so that's repeating words back to you. So if I were to say, hey, Joe, he would say, hey, Joe, back. Okay, so just repeating words back. And echopraxia is also another one, which is basically like they follow the same movements. So if you were to move your right arm, they would move their right arm. So that's echopraxia. And then there are extrapyramidal side effects. Okay, so these are side effects of antipsychotic medications. And extrapyramidal side effects include acute dystonia, which simply means that they have twitching. It could be twitching of the face, muscles in the face. They also have akathisia, so that's what I talked about on the first word there, so that's repetitive movements. And then they can also have pseudoparkinsonism. So pseudoparkinsonism is basically that these medications sort of cause clinical manifestations that are seen in someone with Parkinson's disease. So that might be like your mask-like facial expression, shuffling gait, maybe more apt to be drooling, and things like that. So those are the three extrapyramidal side effects that go hand in hand together. So it's akathisia, acute dystonia, and pseudoparkinsonism. And then we have hallucinations. So these are when people either see or hear or feel or smell things that are not actually present. So hallucinations are most commonly auditory when it comes to schizophrenic patients, but it can be any of the five senses that can hallucinate. That one we've used when we talk about alcohol withdrawal. They feel bugs on their skin, or they see bugs on their skin. So there are many different ways that they can experience hallucinations, but auditory tends to be the most common with schizophrenic patients. And it's important as nurses that we sort of validate that they are safe when they are having auditory hallucinations. So if they are hallucinating, we want to be sure that we find out what that voice is telling them, because it could be something that's harmful, like go kill your roommate, or go jump out this window. Might be suicidal ideations that are occurring. So we have to assess their safety, okay, kind of validate and see what that hallucination is all about. Pseudoparkinsonism I talked about under extrapyramidal side effects. Psychosis is simply when someone is in a state of mind that is abnormal, meaning that they may be paranoid, they may be having hallucinations or delusions. So it simply means that they are in an abnormal mental state. And then tardive dyskinesia. So tardive dyskinesia is actually a irreversible side effect of antipsychotics. So tardive dyskinesia can occur when people are taking antipsychotics. If it is stopped, immediately, once it's recognized, there's a chance that maybe those side effects will go away. But generally, these patients have been on their antipsychotics for a long period of time, and then they develop tardive dyskinesia, which is sort of like that lip smacking, abnormal mouth and facial movements. And they basically aren't going to get rid of that ever. It's irreversible, so they'll have it for the rest of their lives, especially while taking their treatment. And then word salad. So word salad is basically, a method of speech of these patients. And word salad simply means that they are putting together a bunch of different words that make no sense, that have no relation to each other. So it could be, bunny dog over the fence, eggs, green peas up on the car. So it's kind of just all these random words put together. All right. So it is important to know all of these definitions. Of the concept. So your mood, again, that is something subjective. So the mood is something that the patient themselves can describe. So they can be anywhere from depressed, which is like a, sad mood. They sort of don't really have any motivation in life. Might be some high risk for suicidal tendencies when someone is depressed. Okay. Euthymic mood, so that's just a normal average mood. In a normal average person, mood can fluctuate, but then you also have the opposite end is mania. So mania we'll talk about too with bipolar disorder. So this is like a heightened mood where someone tends to act out sort of bizarrely, and they sort of have these grandiose thoughts of themselves that they think they can conquer anything. They're kind of risk takers when they're manic. So that is the difference between the two. But we'll talk about that a little more with bipolar. And then you have affect. So the scope of concept with affect. So this is what we see when we assess our patients, when we are, looking at them. What type of facial expression are they making? That's probably one of the more common things to look at for someone's affect. So blunted affect would be that they have less facial expressions. So if you've heard of like a flat affect, so flat affect would mean that they really have no facial expressions when you talk to them. They kind of just sit there straight-faced and have no affect at all. So that would fall into the category of blunted affect, where someone just really doesn't have facial expressions when you're having a conversation with them. They sort of just sit there stone-faced. Broad affect, so that's just simply meaning that people can, range with their affect. It changes. That's sort of like your normal sort of variation of affect. Okay, someone would be appropriately maybe a little bit more blunted in a sad situation. Maybe they just lost a loved one and they appropriately seem a little bit more flat or blunted. Then that's appropriate. And then they'd seem more excited and whatever in a happy situation. So broad affect meaning that they can range between the, two ends of the scope of affect. And then your labile affect. So this is someone who is sort of can go from maybe being hyperexcitable at one point, being very crying over something. They're just sort of inappropriate. Their affect is all over the place. They kind of just don't sort of match the situation that they are in. Okay. So economic and social factors, like rapid changes, if they've had a huge change in their life, they are at risk for, schizophrenia and bipolar disorder. If they've had any, say a major loss in their life, something that's changed significantly. Stressful work conditions over time, and also if they isolate themselves. Unhealthy lifestyles, substance abuse is a huge risk factor for these disorders. Exposure to violence, so being a victim of violence. Personality factors, just simply the way someone was born, what their personality is. Sometimes we'll put them at risk. Spiritual factors, cultural factors. Changes or impairments in the structure and function of the neurological system. So it is thought that patients with schizophrenia may have some abnormal, brain anatomy, and it hasn't been, 100% with every single schizophrenic patient, but what they've found is that they tend to have abnormal structures within their brain when they do scans, MRIs, etc., to look at their brain. Psychosocial development level and issues, so maybe if they didn't go through all of their schooling, maybe they stopped school when they were in elementary school, they may be at a little bit higher risk for development of schizophrenia or bipolar. Genetics plays a role as well. It is thought that patients who have, parents who either have schizophrenia or bipolar are at higher risk for getting diagnosed with schizophrenia or bipolar as well. And then neurochemical changes. So in schizophrenia, it is thought that there is a huge correlation between the neurotransmitters dopamine and serotonin in these patients. So they have abnormal amounts of these neurotransmitters in their brain, which has been found to be linked to schizophrenia. Your assessment. So a lot of it is, interviewing patients. So you want to determine the patient's mental ability to complete the health history. So if these patients are schizophrenic, for instance, and they have altered thought processes and they're unable to really put together a complete sentence, they're unable to answer a direct question, they may not be appropriate to ask them, their history. Also past medical treatment for mental health, counseling services, family history, ability to carry out ADLs, if they use any substances, current stress in life, suicidal ideation, and suicidal attempts. So speaking of suicidal ideation, suicidal attempts, these patient populations are at extremely high risk. So I believe it's, pretty high percentages. I forget off the top of my head, but with schizophrenia and also with bipolar, high percentage for risk of suicidal attempt. So that is very important to know. Also with examination, you want to kind of do a pretty good neuro exam and assess again their mental status, their orientation. So these patients may not be oriented, or it might be really hard to even figure out if they're oriented because their concentration is so poor. So if someone's maybe really depressed, they may not be interested. It may be hard for them to concentrate on the discussion that they're having. And then same goes for the opposite end of that. If someone is more manic, they are sort of bouncing from one thing to the next, switching subjects, with the snap of a finger, they're on to talking about something completely different. So it's hard for these patients to concentrate sometimes. Their posture, so how are they sitting? If they're depressed, they might be more slumped over. Level of anxiety, a lot of times these patients have anxiety. Level of appropriateness, again, kind of goes hand in hand if they are able to answer questions appropriately, etc. Labile behaviors, so those are like our clinical manifestations we'll talk about in a little bit. Inappropriately dressed, so especially schizophrenic patients and patients who are bipolar in the manic phase, they tend to dress very inappropriately. So I have an example here. In the cold weather, you might see them wearing, shorts and a tank top or something. So they're dressed really inappropriately, or vice versa. It's summer and it's hot out and you see them in sweatpants and a sweatshirt and a hat. So they kind of can't distinguish what is appropriate to wear. Abnormal speech, so there's different speech patterns we're going to talk about with schizophrenia. Observe different thought processes that they may have. So again, we'll talk about those in schizophrenia. And again, big thing, underline it, is suicidal tendencies. So schizophrenia. So schizophrenia is one of the more common psychotic disorders. There are, many different things that are sort of, what am I trying to say? Like sort of incorporated in what schizophrenia looks like. Many different clinical manifestations that patients can have. So that's why you see here in the first sentence that their, symptoms have many different varieties, and it is, diagnosed by looking at all of their clinical manifestations that they are having. And the DSM, the Diagnostic Statistical Manual 5, is what is used to sort of diagnose that someone has schizophrenia based on their clinical manifestations and how long they've had them. The exact cause is unknown, okay, but it can result from a combination of genetic, biological, cultural, and psychological factors. So remember I mentioned earlier that someone could just have abnormal brain development or abnormal structures of the brain that is thought to sort of play a role in someone developing schizophrenia. There are individuals who can live successfully in the community, and it is very important that for them to live successfully in the community that they are adhering to their treatment regimen. Diagnosed late adolescence or early adulthood, so generally anywhere between 15 to 30 years old. on average. It's estimated about 1% of the total population in the U.S., and the risk for suicide in people with schizophrenia averages about 5%, but it can be anywhere from 10 to 30%. So that's a pretty high percentage. And then there's something called schizoaffective disorder. So this is basically when someone is severely ill with psychotic, clinical manifestations or symptoms, and it's also combined with mood symptoms. Okay, so mood symptoms, we're going to talk more with bipolar disorder, and we talk sort of about affect and altered thought processes that occur with someone in schizophrenia. So schizoaffective is basically a combination of those clinical manifestations. So we have something called positive or hard symptoms and negative or soft symptoms. So the positive symptoms you can see are all listed here, and these are associated with sort of losing touch with reality. So delusions, we talked about that. Those are the fixed false beliefs that they truly believe something is real when it is not. Hallucinations can be any of the 5 senses. Again, something maybe they're hearing. Auditory is more common in schizophrenic patients, but can be any of the senses. And then psychosis. So with psychosis, this is again sort of an abnormal mental state, and some sort of common symptoms that they may portray is something called depersonalization and derealization. And with depersonalization, someone basically feels as though they are disconnected from themselves. So they basically feel like maybe like they're not in their own body. Okay, so they have like personal boundary issues. All right. Derealization means that they sense that things are not real. So they feel like, maybe the situation they're in is not real. Maybe they're imagining it. They just feel as though whatever's happening to them is not something that is actually happening. It's not real. So with depersonalization, derealization, they tend to have a little bit of personal boundary issues. And also with psychosis, patients can be very paranoid as well. So, just hearing what depersonalization, derealization is, you can see that kind of sounds like someone's paranoid. Like they're not believing that they're connected to themselves, they're not believing that a situation's real. They sort of become paranoid about a situation. Then they also have grossly disorganized thinking, speech, and behavior. So different ways of thinking would be that they have problems organizing their thoughts. All right, so maybe they have things like flight of ideas, where they're jumping from one subject to the next. They can't really focus on the topic that is being discussed. The echopraxia I talked about, that's the following repetitive movement. Like if I moved my right arm, they'd move their right arm. Echolalia is repeating words back. So again, my example was if I said, "Hey Joe," they'd say, "Hey Joe" back. Clang association is when clients rhyme their words. So their sentence may not make any sense at all, but they're rhyming one word to the next. Word salad I talked about, that's putting together a bunch of words that make no sense. They, in a sentence together, have no association between each other. They may be ambivalent, meaning that they kind of really don't feel like they can commit to one thing. They're a little bit sort of back and forth. They don't know if they really trust you. Maybe they do trust you, and they're ambivalent about maybe a situation they're in, or their feelings, or their treatment even. And then perseveration, so that would be that someone is sort of fixed on say a certain sentence, and they just keep perseverating on it over and over again. Or maybe they keep perseverating about their dog or something. They just can't stop talking about their dog. They're so fixed on talking about a certain topic, and it's hard to stop them from talking about it. Negative or soft symptoms, to me, are sort of like your depressed symptoms. So I think of like negative, depressed, feeling negative. So they have the flat affect, which we know means that they have little to no face expression when you talk to them. Avolition just simply means that they have no motivation. They really don't motivate themselves to carry out their ADLs. They may withdraw themselves or isolate themselves socially, so they tend to be alone purposely. Anhedonia means that they do not feel any pleasure in life. They have no interest in life. Again, may lead to decreased social interaction, so they may sort of withdraw themselves socially. Apathy is just having no feelings. Blunted affect, I talked about earlier, minimal facial movement or expression. And catatonia, so this can be, either like a posture that they hold, or a weird movement that they keep doing with their arm, or they hold themselves in these weird positions or postures, and they kind of don't care what is going on around them. They hold themselves still. And then inattention, so basically meaning that they have limited attention span, a hard time concentrating. All right, so it is important to know the differences between the positive and the negative symptoms. Just understanding that like delusions would be a positive one and flat affect would be a negative one, so on and so forth. So I would be familiar with these. So there are different types of schizophrenia. Paranoid, meaning that they have a lot of suspicion. They are sort of on that line of being psychotic or experiencing psychosis. So they tend to have a lot of hallucinations and delusions when they are paranoid. Disorganized is the most impaired form that they can have. It's oftentimes seen with the homeless population. They don't really take care of themselves well. They have inappropriate affect, disorganized speech and behavior. And then your catatonic schizophrenic type would just be their abnormal motor behavior. So it can be extreme motor agitation or retardation, meaning that they hold themselves in a certain position or posture. These are some treatments with medications, pharmacological treatments. So you have your second generation antipsychotics. So these are ones that I do want you to be familiar with, but I'll tell you a couple things that I want you to absolutely know about some of them. So the way I put this together here is that you can sort of see there are common side effects that often occur with these medications. So up at the top, you see sedation, hypotension, extrapyramidal side effects, EPS, and anticholinergic side effects. So these medications have a tendency to cause these side effects, when patients are taking them. So I put it together in a way that you can see sort of how common each of these side effects are. So it helps to organize it, hopefully, for you guys. So Zyprexa, you can see, has a lot of sedative effect when someone takes it, okay? They only have significant hypotension effects, mild extrapyramidal side effects, and moderate anticholinergic effects. All right, so you can see sort of how it's set up there. So some of the important things that I do want you to be familiar with is that Clozaril or clozapine can cause like agranulocytosis. All right, so that is something that would need to be monitored with patients who are taking Clozaril. So like complete blood counts should be followed. And then Seroquel or quiptapine is basically a risk for prolonged QT intervals. So that puts you at risk for dysrhythmias. All right, more specifically, if someone has a prolonged QT interval, they're at risk for torsades. Our first generation antipsychotics, so these again are pharmacological treatments, and it's set up similarly, so you can see their side effects that they have that could be very significant or rare. So with Thorazine, this again needs to be monitored for any bone marrow suppression, like agranulocytosis again, so monitoring your CBC levels. And the other side effect is from Haldol that I want you to be familiar with. So Haldol also puts you at an increased risk for prolonged QT intervals. So with Haldol, you also want to watch their QT interval because they're at risk for dysrhythmias, more specifically torsades. So nursing considerations. So very important things, suicide and safety risks, okay? Always assessing their safety risks. That means the environment around them, okay? So a secure milieu, simply meaning environment, safe environment. They may need a structured environment so that they sort of have like a routine that they have day in and day out. So it's structured for them. Also establishing a trusting relationship. So that's very important with these patients. You want them to feel comfortable and trusting when you are caring for them so that they can openly discuss like their feelings, maybe hallucinations that are occurring. You want to be able to have that relationship. Avoid direct questions. So this can cause a client to feel threatened. So you may, offer them like open-ended questions. That way they can sort of talk about their feelings, etc. And you give them that open-ended question and then provide some silence for them to have time to put together their thoughts. Because remember, these patients have a hard time putting their thoughts together. So you provide silence in order for them to gather their thoughts and answer you with whatever the question was about. Maintain therapeutic, objective, clear, concise communication. So using a calm tone, address the client by name. You want to watch for escalating behavior. So if you do have someone who is escalating with their behavior, maybe, you can tell that they're starting to get really sort of anxious and active, and maybe they're sort of bugging other clients on the unit. You may have to sort of distract them and maybe bring them into another room or bring them to an activity that they can do, and, sort of distract them from their escalating behavior. But if someone's unable to be maintained and they keep escalating, they become unsafe, then it's important to also think about possibly secluding them and possibly even using restraints if their safety is at high risk or they're at high risk for harming somebody else. So that's if they're escalating their behavior and it's hard to control them, that you would seclude them and use restraints as needed. Tolerate silences, I talked about. Reduce stimulation, solitary activities. So simple activities are best for these patients. For instance, things that will promote positive self-esteem. So you want to do things like art, finger painting, clay, and you do not want to engage in competitive activities because competitive activities can just lead to escalating behaviors. We'll talk about this in class. That's B. Number 2, also B. 3 is A, because remember catatonic can be purposeless motor agitation or retardation, meaning they hold it still. Number 4, so if someone's having hallucinations to kill a roommate, one-to-one observations should be implemented to provide safety for both the client themselves and the roommate. So on to bipolar. So this is also a common psychiatric diagnosis, and it's actually the most common associated with suicide. So, that kind of rings a bell probably if you guys underline suicide. That's something huge to monitor for safety. It is thought that there are neurochemical risk factors of bipolar disorder as well, imbalances between serotonin and norepinephrine, hormonal fluctuations, genetics, so again, family history. If your parents had bipolar, you're more at risk. Psychosocial stressors. Bipolar disorder is diagnosed when a person's mood fluctuates to extremes of mania and or depression. So it's the second most common mood disorder. And there are different sort of levels per se. So bipolar 1 simply means that they have one episode of mania and one episode of bipolar. And, within the year. And then bipolar 2 would be that someone has an episode of hypomania. So that's sort of like a lesser version of mania with a cycle of depression. All right, so the difference between the two is that bipolar 1 is, absolute mania with a cycle of absolute depression. Bipolar 2 is a hypomania cycle, meaning a lesser degree of mania, and also a depressed cycle. Okay, and then you can have mixed. So mixed or fluctuating simply means that patients sort of go in and out their cycles, sometimes multiple times throughout the year, like 3 to 4 times, etc. So they're kind of in and out of all these cycles. The first manic episode generally occurs between teenage and 30 years, so pretty similar to schizophrenia, like in the teenage to 30 years. According to the World Health Organization, bipolar disorder is the 6th leading cause of disability. It's equally diagnosed between men and women, more common in highly educated individuals, and young men who are in the early course of illness. So maybe this is like your late teenager who's diagnosed, just as an example, are at the highest risk for suicide. So again, these patients, huge risk for suicide and safety. They can be manic and they can be depressive. Okay, so manic is more that sort of heightened mood that they experience. Oftentimes comes on suddenly. They have symptoms over a course of a few days, can last weeks for these patients. They're euphoric, meaning that they have these grandiose thoughts, grandiose mood. They just feel like, this is the best few weeks of their lives. They can conquer anything they need to. They are attention seeking. All right. They oftentimes kind of partake in high risk behaviors because they have poor judgment during their manic phase. So again, safety comes into play there because they may go and try and do something that really they can't do on a normal day, but because they're manic, they think they can do anything. So they're going to try it. Exaggerated self-esteem, so they think everybody loves them. They think they're the best, the most beautiful person in the world. Sleeplessness, so these patients maybe will sleep an hour or two a night, but oftentimes are exhibiting insomnia where they're up like 24/7 almost. Pressured speech, meaning they talk really fast and kind of under pressure. They're increased talking, meaning they talk a lot. Flight of ideas, jumping from one idea to the next sort of rapidly, doesn't really make sense of what they were just talking about. They're kind of just talking like on and on and on, jumping from topic to topic. Increased energy and possible presence of hallucinations and delusions. Okay, so that's your manic cycle. And when I talk about hypomania, that means that patients can have some of these symptoms, but maybe not as severe. Okay, so when I talked about the hypomania with the bipolar 2. And then your depressive, so this is kind of like your sad clinical manifestations. So they slide into a depressive state over time, can last weeks to months. Again, popping up is that flat, blunted affect. May have a lot of crying, tearfulness, anergia, meaning no energy to do anything or to carry out their ADLs. Anhedonia, not feeling any pleasure in life, not interested in life, difficulty concentrating, self-destructive behavior, so that could be like self-inflicted harm. Okay, so making sure that you're assessing for that as well. Decreased appetite, disturbed sleep, and psychomotor agitation retardation. So that could be like your catatonia. Okay, so with depressive patients with disturbed sleep, they may be sleeping, all day. Maybe they don't want to get out of bed, that sort of thing. Logical. So lithium. So it's important to know about lithium that there is a therapeutic level, and it's listed here for you. So it's 0.6 to 1.2. So it is important to know because patients can become toxic. So if someone does become toxic, it's most likely because their level is greater than 1.2, but there's some cultures that can possibly even become toxic before that higher end of the therapeutic level. So it's important to recognize your symptoms of lithium toxicity as well. So that would be like your kind of sort of classic signs and symptoms of any overdose or toxicity would be vomiting. They may have ataxia, meaning abnormal motor movements with their muscles. They may be drowsy or lethargic, weak, tremulous. All right. And remember that we talked about lithium in the metabolism lecture, that it can lead to hypothyroidism. So it's important to monitor thyroid levels. There is a patient population that lithium is really contraindicated for, and that would be anybody who is on a sodium-restricted diet. All right, it's also not recommended for pregnant women either. It's because when people are on lithium, you want to be sure that they are taking in adequate fluid and taking in adequate salt, okay, a steady diet. And it's very important for them to remain compliant with their treatment. And sometimes people are looking for, immediate results when they start lithium, but it doesn't happen that way. It usually takes a few weeks in order for the lithium to, be, what's the word I'm looking for, like increase to that therapeutic level. So it'll take a few weeks for people to see that it is taking effect. And then you can see anticonvulsants are also prescribed in these patients. So just a couple of the therapeutic levels I want you to see there. For Tegretol is 4 to 12, and for Depakote it's 50 to 100. And then your SSRI antidepressant, so fluoxetine or Prozac. So this is another medication that can take weeks to sort of kick in. So it's important to educate patients that it could take weeks. It's not going to just happen as soon as they start taking it. So monitoring for suicidal ideation in those first few weeks before it actually kicks in is important. And then also monitoring for something called serotonin syndrome. So serotonin syndrome can happen with many different antidepressant medications. So your SSRIs and also your SNRIs. And what serotonin syndrome is basically increased levels of serotonin that are circulating in the body, so neurotransmitter. So your clinical manifestations are going to be a labile blood pressure. They're going to be very agitated, have a change in mental status. They may have tremors, may have a little bit of muscle rigidity. And when you see these patients, they kind of act very bizarre when they have serotonin syndrome. I have seen a few of them in our ICU, and it's very hard to sort of keep them safe. They're sort of like all over the bed, very agitated, restless, can't sit still. Their blood pressure is all over the place. It's very high one minute, it's low the next. Sort of just very unstable. So it's important to recognize those symptoms. And the treatment for that, if it does occur, would be to stop whatever is triggering it. So in this case, it would be stopping the medication, stopping the antidepressant, and just supporting them while the medication sort of clears from their system and return back to baseline. ECT is a treatment for bipolar disorder, and basically what it is a sort of like a electrical impulse that is given to your brain, and it sort of induces a seizure for these patients and sort of restarts the chemicals in the brain. So it kind of helps you to rebalance all your neurotransmitters per se. So it is a induced seizure that occurs with electroconvulsive therapy. And it used to be thought of as a very barbaric treatment because they did not used to give any pain medications for ECTs, so people would be very uncomfortable while they had these, seizures induced by electricity to their brain. But this day and age, patients are oftentimes given something for pain, something for sedation, so it's a lot more sort of comfortable for them as they undergo this procedure. So with these patients, pre-procedure, you do want to be sure that they have been NPO. It's almost like like a preoperative type thing. So NPO, make sure that, they should or should not have taken any certain medications that the doctor wants them to, etc. And during the procedure, basically your priorities would be airway. If they're receiving sedation, pain medication, they're going to be having a seizure. You want to make sure you have patent airway, monitor blood pressure, that you have IV access, and all of that sort of stuff. And then post ECT is ensuring that, again, their airway is protected, that they have a positive gag reflex before they are given anything PO. Also, some patients may complain of a headache after ECT, so that is expected, and treat their headache with pain medication. Also, they may have short-term periods of confusion, maybe a little bit of like short-term memory issues initially, but there should not be any long-term memory issues associated with ECT. And patients will undergo ECT for a few months. They may have to undergo it for 2 months, 3 months in order to start seeing any results. So it's not like it happens, after one treatment that someone is cured and, their mood is stabilized. Very important, safety, all right, suicidal tendencies, limit setting. So this kind of applies to patients who are manic, if they are sort of unsafe or maybe causing disruptions in the environment, the milieu, then you're going to have to sort of set their limits and make sure that you verbalize those limits so that they are aware of their limits. Decrease stimulation. So again, keeping it calm, secluding them if they have to be secluded. If they are in a manic state and maybe they are very disruptive, they may need restraints also. So that's just as needed. Monitor for escalating behavior, kind of goes hand in hand with what I already talked about with schizophrenic patients. If they seem to be bothering other people around them because they're escalating behavior, then you want to be sure that, you separate them and maybe distract them with a snack or an activity, or, maybe go read a book, something like that. Calm, matter-of-fact communication, consistency of staff members, so same nurses assigned, helps with familiarity. That way they become more trusting of the nurses, and you can develop that trusting relationship, therapeutic relationship. Promote rest and sleep. So your manic patients are not going to sleep, so you're going to want to try to introduce activities that may help them to feel tired. So maybe monotonous activities like, hey, fold this stack of face cloths here, and they just kind of fold things over and over and over. Very monotonous, boring task that might make them feel a little bit more tired. And then diet for these patients. So finger foods are great because they oftentimes are either manic and can't sit still to sit down and eat a meal, or maybe they're depressed and they really don't have any interest in sitting down and eating a meal. So finger foods are something quick that can be given to these patients, sort of they can just eat on the go. It's just a little bit easier for them to get their nutrition. So high calorie, high protein finger foods are best. So your questions here. So D. So lithium levels, that's high. Remember, it's 0.6 to 1.2, so 1.8 is elevated. You're going to hold it. Prozac can take a little while to, take its effect. So monitoring for 2 to 4 weeks, and also monitoring for increased suicidal ideation during that time.